Hello, everyone. Welcome to our fourth day of the daily ISKI Hot Tip series. We're going to let more people come in before we do the whole introduction. But as you can see in the camera, we have some very familiar guests, Cardiff grads that most of you probably know. Okay, yeah, so today this session would be on how to ace specialty and explanation stations, and we have two of our guest speakers, Dr. Faris Hussain, who was the ex-president of Cardiff MedSoc, and we have Zaid Attia, Dr. Zaid Attia, who was the ex-president of Cardiff University Surgical Society. So they'll be delivering the session, and I think we can have a 2-minute wait now to let more people in, and then I'll hand it over to the two of you to start.
Okay, sounds good. Thank you.
Thank you, Anthony.
Okay, so just a few reminders, guys. If you have any questions at all, please put them in the chat. We'll try our best to answer them as we go or pass it to the speakers. But if you do have a lot of extensive questions, we are doing a question and answer session tomorrow, especially where we will go through some frequently asked questions and can have questions from from the audience as well. But anyway, now over to Zaid and Faris.
Thank you, Anthony. So as Anthony very kindly introduced us, my name is Faris. I'm currently one of the F1s working in Wales. And Zaid, do you want to just briefly introduce yourself again?
Yeah, hello everyone. I'm Zaid. A lot of you might know me actually because you guys were in my cohort. I've graduated from Cardiff last year. And for those who don't know me, you might have bumped into me in the library, considering it was my place of residence for the past 5 years. So I'm sure we've crossed paths. But yeah, hope you find this session useful.
So what we're going to go through, we're very briefly going to go over the nations can fit into those. I'm expecting that all you guys, given that your exams are very soon come in, that you'll all be familiar with that. And then we're finally going to go through a little bit of my personal experience with those types of stations that are similar to the stations that you're going to have, and we're both going to go through our personal tips. Just a disclaimer, so myself and Zaid, we sat the ISKI in May of 4th year, where it was a different format to what you guys are sitting, where we had 12 stations over 3 days. So it's very clearly a different format to what you guys are having upcoming. So there's obviously going to be some differences in our experience and tips, but broadly speaking, our advice should be applicable to what you guys are going through. So essentially, this is what your ISKI looks like. And the way that specialities and explanation stations can fit into that is essentially through what I think will be most likely these 3 types of stations. So your communication station, your interprofessional communication station, which is essentially the SBAR station, and the clinical pharmacology station, which is one which is brand new for this year. Just to briefly go over the format for these. So as I'm sure you're all aware, the SBAR station is a 4-minute history followed by standardized questions, which includes handing over to a colleague over the phone. And then it tends to be management questions. So back when Zaid and I were sitting the ISCI, we were guaranteed to have an SBAR station over the 3 days. And this was always an obs and gynae station. So for each of the 3 groups who sat their ISCI back in 2019, in May 2019, we always had an obs and gynae station. It's very plausible that your interprofessional communication station is reasonably likely to be an obs and gynae station. However, part of the reason why they've changed the ISCIs the way they have done, not only has been in response to the pandemic, but has also been to try and stop students from tailoring their revision in a specific manner, so that they're thinking, if you've got a specialities day coming up, then I need to prepare for the SBAR station only with regards to obs and gynae. They've deliberately done that. And I know that they have written stations which are not necessarily obs and gynae for this type of station, just to be aware. However, there still are a high number of stations that they have written which are obs and gynae ones. So my advice would be, when you are prepping for this, is just to have an open mind and not to tailor sort of your mindset to think that only an obs and gynae station will come up with this type of station. The communication station and the pharmacology station are essentially of a similar sort of structure. You have a brief history for about 7 minutes, where if you're in a pharmacology station, the chances are you're going to have to talk through with the patient some explanation of their medications, most likely. It may be that you have to explain a particular condition or answer other questions related to what's happened to the patient recently as well over the 7 minutes. And then you'd be expected to present back what you've just talked to about with the examiner, and then answer standardized questions related to investigations and management. My key advice would be, because obviously this is a new type of station, the most similar type of station that is to what Zaid and I sat is the psychiatric explanation station, where we had 11 minutes to talk through a psychiatric medication or condition. And essentially one of the reasons why they reduced, why they got rid of that station is essentially because 11 minutes for most people was way too long. Most people, I found, tended to be done with their explanations by about 7 minutes, maybe 8 minutes. And then there was usually, for most people, a few awkward minutes of silence, which is why they've not included the format of that station with your round of ISCIs. So my advice would be, just bear in mind what they're asking of you, and make sure that you ask the actor in front of you, the patient in front of you, what questions they have for you, because the chances that you have is that the pharmacology station in particular, they'll have questions that they want, that they are expected to ask of you. So just bear that in mind as you're going through. And in the communication station, when you have to do a 7-minute history, you would have done in second year, and you guys should all be excellent at doing this from having done your GP blocks. And just remember, the chances are that the conditions and the things that you will be discussing and taking histories for will mostly be based around general practice and things that you commonly see either as a GP or as an F1. So the next lot of slides, I'm just going to briefly go through the types of stations that are similar to the ones that you're going to get, essentially, that I had when I sat my ISCI, and the feedback regarding that, and what I particularly learned and what I would advise you guys. So this is essentially a communication station, but back when I sat it, it was the psychiatric history station, where you have to do a 7-minute psychiatric history followed by a presentation of that history and then answering standardized questions. As you can see, so I passed this station reasonably okay. The main feedback that I got from the station was regarding psychiatric first aid. So the history was reasonably straightforward. It was a psychosis history. And then the questions after that tended to be related to the patient had self-harm / suicidal episode and what you would do in response to that. And a lot of what I talked in regards to the management tended to be I suppose quite niche, complex things that I'd learned from my psychiatric block and from being interested in psychiatry. And I think looking back, I forgot a lot of the common sense things, like saying that I would actually talk to the patient and approach the patient. So just bear that in mind when you're coming up with similar scenarios. So Remember, if you do have any emergency scenario, always to say that you do an A to E assessment. If you've got an emergency psychiatric scenario, remember that you would go and say that you would assess the patient. Just remember those common sense things when you're approaching emergency related questions, which you're most likely to get in the question section of any station, let alone the communication one. With regards to the explanation station, so this is a station I actually did reasonably well at. So I had to explain lithium to a patient. And my key advice for this, I've already mentioned, is essentially to establish what the patient already knows, whether you have to explain a medical condition, whether you have to talk through a medication, or whether you're talking to the patient about something that's recently happened to them. If you just ask them what they know already, it saves you having to repeat a lot of the simple things straight away. And then if you respond to that question and then ask them if they have anything in particular they want to know, the actors will have a set list of questions that they have to go through. It's usually about 4 to 5 questions. And essentially when they get to the end of that, they will say something along the lines of, is there anything else you think I need to know? When you get to that point, you know that you've gone through all the core questions that are required of you at that station. And then essentially you have 2 options, I thought at the time when I was sitting in this type of station. So because you had 11 minutes, you could either leave, as I said before, an awkward few minutes of silence, or you can do what I did, which is essentially, if you felt confident enough, you could just go on explaining more and more about the condition or the medication. So I did that with my station, the lithium station. My advice would be for you, because you've only got 7 minutes usually to talk through whatever you have to do with this pharmacology station, I would just advise that you use all of those 7 minutes, because that is a lot shorter time than 11 minutes. And as I'm sure you guys know from practice, the supply within any excuse. So this is a communication station. So again, it was a 7-minute history. This is the actual, this is the station out of the 12 that I did fail. And I think the main reason that I failed it was because I overcomplicated things. Essentially, the history was a reasonably straightforward obithic vaginitis, so typical symptoms. And I took that history reasonably well. Compared to perhaps some of my other histories, I wasn't as, I suppose, compassionate, I think, in my communication, which is why I've got the feedback that I had. This was on my second day, and I was feeling a bit disheartened after the first day and a bit tired. But essentially, I started to unravel after I presented my history, where I said my top differential was atrial vaginitis. But I remember being shown a picture, which was of a vagina with findings of atrial vaginitis. But I thought that was too easy, that was too simple to be true. And there must be something else going on. There must be a prolapse or something along the lines of that. So essentially, I overcomplicated the situation. I incorrectly described what the image was showing me and listed all the sort of red flag investigations that I could think of. So my top tip from learning from this station would be, if it seems straightforward, the chances are it probably is. So I was examining at the formative year 4 ISCEs yesterday, and a couple of the students, they started off doing the history part of the station quite well, coming up with the correct differential. But then as they went through the station, it almost felt as though they thought they were missing something, and they came up with other differentials and basically overcomplicated the station, whereas it didn't need to be. Just remember, you are being assessed at the standard of a final year medical student. You're being assessed towards the end of your time at medical school. You're not expected to be at the level of the registrar/consultant where you're diagnosing super rare conditions. The chances are you're going to come up with common presentations that you're expected to see as an F1 or in a GP practice. So just remember that on the day. And then finally, with regards to the SBAR station, so I think Zaid would agree with me that when you come to being an F1, you actually tend to do a lot of these handovers nearly every day as a junior doctor. So you will get very good at them. My top advice from learning from this, so I thought I was okay at this station, not particularly exceptional. But what I learned, I think, from being an F1 is don't worry too much if you can't rigidly stick to the SBAR structure. As long as you broadly follow that and get to the end point of what you're asking for, that's the most important thing. My top advice is when you introduce yourself over the phone, make sure you clearly state who you are, what team you're calling on behalf of. So for most of the scenarios that you most likely have, that will probably be from the GP practice or from the emergency department or assessment unit. Say immediately why you were calling. So for example, I'm on intensive care at the moment, and most of the calls I do are for asking for scans. So what I tend to do is say, hello, my name's Faris Hussain. I'm a junior doctor calling from critical care in UHW. I'm looking after a patient at the moment. I'm concerned this patient has a PE. I would like to discuss requesting a CT scan with you, please, if that's all right. If you say that broadly in your first line, you've immediately said where you're calling for and why you're calling the person that you are. Most of the time with these types of scenarios, it will be escalating the patient. So just be very clear, sort of what differential diagnosis, what emergency are you thinking in your head when you're presenting this? So with this station, my patient that I'd taken a history from had a suspected miscarriage. So essentially I said that within the first line. So those are my top tips and the lessons that I've learned from when I actually sat the SG. So I'll hand over to Zaid now for the next few slides.
All right, thank you very much, Faris. That was quite comprehensive and really relevant. Hello guys, so my slides are going to focus primarily on tips pertaining to pretty much every station really, but primarily the ones relating to explanation stations and communication stations. As Faris has emphasized, this is purely based on our subjective experience through ISCI. So it's not, it's not something that university has told us exactly, but we've also sort of included the salient points and consulted friends and colleagues of ours from our cohort and previous cohorts as well regarding what they think is most relevant. So I'll start by saying that, the communication and explanation stations are primarily there for you to actually demonstrate your ability to engage with the patient and demonstrate good rapport, okay? This is not a conversation. Don't speak at the patient, don't speak to the patient, speak with them, okay? The conversation needs to allow itself to flow quite nicely and naturally. Don't lecture the patients. I know it's tempting to, feel the need because of the 7 minutes that you have, which is quite a condensed period of time. It's quite tempting to just vomit and regurgitate everything that you know, just to prove to the examiner that you know what's happening. But really, these aren't knowledge stations. These are meant for you to unpack the patients and really address their concerns. So as a general rule of thumb, if you find yourself speaking more than 2 minutes straight without having the actor or the actress, engaging with you or reciprocating, you're doing something wrong. So make sure it flows nicely and make sure they reciprocate. Have structure, that's incredibly important. Patients can sometimes take you off their track and go on tangents, but it's important to take control. This is purely my opinion, but I would recommend that from the onset of the encounter, you lay out or give the patient a nice overview or a skeleton of what you're going to discuss. For example, if you've been asked to discuss a medication, I would personally say, I'm here to discuss or talk to you about this new medication, sertraline, that you've been prescribed. I'm going to start to talk about what the medication is, why it's been prescribed. I'm also going to then move on to talk about important, common and dangerous side effects pertaining to that medication, and then address any questions, concerns and expectations that you have. Okay, so it's a few seconds really, but it gives the examiner the impression that you are organized and structured, and it limits the actor's ability to essentially throw you out of your pre-rehearsed scripts. But also demonstrate flexibility. Again, this is a communication station. It won't be very rigid. So personally, what I would recommend is to show the examiner that you actually have an understanding or an insight into how these encounters work in real life, because you want to make them as authentic as possible. Address the fact that these can be quite difficult encounters to have, especially if it's a psychiatric, for example, station where you're talking about bipolar or suicide ideation or depression. So show the examiner that you know that this is a difficult conversation to have. Say something along the lines of, I completely appreciate that the topic that we are discussing is a very sensitive or a difficult topic for you to discuss. By all means, if you do feel the need to stop or have a break, please let me know. Now, the patient's not going to do that, considering they're very aware of the fact that this is an exam condition, but you've demonstrated to the examiner that you understand that in real life, these things do happen. Moving on, establish what they already know. In ISCIs, this is usually little to nothing. It's something very underwhelming, but they do like you to not just jump in immediately and establish what they already know, and perhaps more importantly, what they want to know, okay? ICE them, this is very important. ICE is not something revolutionary. This is something that we've been taught from pretty much day one of year one of medicine. But the reason I emphasize this very, very much is because in my, at least my experience from communication and explanation stations in Cardiff, is that there is always something that the actor is harboring that you as a candidate is expected to unlock. And they're not necessarily always going to volunteer that with you. So I would really be very, very explicit and direct with icing the patient. Do you have any questions? Do you have any concerns? Is there anything in the back of your mind that you'd like me to discuss? And really, if they mention something, make sure you dedicate a period of time to addressing that, because that's usually where all the marks are going to be. Now, I've highlighted the C, which is concerns and ICE in red, because it brings me nicely into my next point, which is in comms skills and explanation stations, have a very low threshold for exploring abuse or non-accidental injury, okay? These are pitfalls that candidates, friends of mine, colleagues have actually failed stations before because of missing. I'm not saying that to sort of discourage you or scare you, but these are very important things that you cannot miss. Abuse is particularly hot or popular in obstetric stations, and non-accidental injuries, are particularly popular in pediatric stations. I'm going to provide an example from each. So abuse, my mind goes back to a station that came back 2 years ago, I believe, my friends have told me about, pertaining to essentially a woman who came up with an intrapartum hemorrhage. So the actual station revolved around a placental abruption, which was fairly straightforward. But candidates who failed to pick up on the fact that the patient was actually physically and domestically abused by her partner, hence the trauma, the physical trauma that she sustained and the abruption, failed the station. So have a low threshold of exploring that. The same with non-accidental injuries, pediatric stations, always look at the patient in front of you, think, is my patient either directly or indirectly vulnerable? Am I dealing with an elderly patient who's possibly demented? Am I dealing with a patient with learning disabilities who can be easily exploited and taken advantage of? And always, always, always ask about the social circumstances of patients, especially pediatric patients. NAIs are very, very hot. The one that comes to mind is also a station that came out 2 years ago, I believe, that my colleagues have had, which related to failure to thrive. So failure to thrive is a very common pediatric station, as you guys know. It's a very hot, popular topic, and it's multifaceted. But candidates who did not also pick up on the fact that the patient was actually neglected, and remember, neglect in itself is a form of abuse, so it's not always your classic sort of physical, sexual, verbal abuse. Patients who have been neglected can present with safeguarding concerns and failure to thrive. So candidates who didn't pick up on that scored quite lowly, and I think were red flagged or possibly even failed that station. So always explore that. This is a friendly reminder, as I've just mentioned, that abuse exists in many forms: physical, sexual, financial, verbal. So have an open mind, have quite a large scope of things. And like I just said, I don't want to repeat myself, neglect in itself is a form of abuse. And think of that in pediatric stations, especially where there's a global developmental delay as opposed to isolated, because it tends to affect all aspects of development, and patients who fail to thrive. The station that came up 2 years ago, I think, was relating to the one that I told you about, failure to thrive. I think was the problem that they were feeding the patient or the baby one particular food, I think, and they were neglecting other aspects of their diet, etc. So it's quite specific and niche, but they do expect you to really hone in on that. Moving on, risk assessment is incredibly important, especially in psychiatric stations. This is something that you cannot miss, and I would advocate for you to actually put that early on during the station, fearing that you might lose time in the end. So, don't start with it, but certainly a few minutes in, once you feel like you've established rapport, risk assess the patient very well. So this includes risk to self, which we all know, risk to others, and suicidal ideation. Do not fear or don't beat around the bush. Suicidal ideation is something that you're expected to address. Don't fear being too blunt or too direct. Phrase it sensitively, but also directly. You want to show the examiner that you are highlighting this issue very importantly, okay? I cannot emphasize this enough. If you are dealing with patients who are vulnerable, you have to risk assess not just the patient in front of you, but other people around. So if you feel, for example, like, there's a child in front of you that may be at risk, ask if there are any siblings, for example, in the house that may be also at risk. So have an open mind. You're not just risk assessing the patient in front of you, you're risk assessing the entire household. You're risk assessing the social situation that the patient is in. Next slide, please, Faris, if that's okay. Moving on, this is for some reason a controversial point that I myself don't understand why. I think personally it's very necessary. If anything, it's mandatory in communication and explanation stations, which is obtaining a history. It's not the most important part of your station, but it can be quite disastrous if you do miss it. I would say keep it brief and very much confine it to past medical history and drug history, okay? The reason being, and I'm going to give you an example of this, is if you, for example, get given a station where you say, for example, you're expected to explain sertraline, an antidepressant, for example, it's very important to be aware of the patient's past medical history, provided it might actually relate to the medication. So ask the patient, are you known to have any medical conditions? More often than not, they will say no, for example, but I would take that a step further to demonstrate to the examiner that you know what you're doing and that you're aware of the side effects of, for example, sertraline, and ask specifically, are you known to have a history of, peptic ulcer disease or stomach ulcers, or are you known to have seizures? Highlight common side effects or relative contraindications to the medication that shows the examiner that you know what you're doing and why you're asking. Same thing relates to drug history. I won't dwell the drug history too much, but I would very much ask you to, ask the patient what drugs they're on. Cardiff doesn't tend to put things in for no reason. They don't waste your time. So if the patient's on a particular set of medications, think long and hard about why that might be. Classic examples would be patients being on anticoagulants when you're prescribing an SSRI, that itself increased the risk of peptic ulceration and bleeding. Another very important example would be, loop diuretics, for example, like benzoflumethiazide or ACE inhibitors in the context of lithium. We know that these medications can alter the bioavailability and the efficacy of that medication. So think about that and ask specific questions relating to that medication. Tailor your question to that medication and flex your knowledge to the examiner. Never forget allergies. I think that's fairly straightforward. We can't really forget allergies. And pregnancy, I'm going to highlight in red because it can really be a part of your station that you can overlook very easily, and that can have quite an impact on your mark. I can't stress this enough. In the context of medications, you want to make sure that the medications you're prescribing are not teratogenic. I had a female patient for my lithium station when I had to explain it. I was actually commended in my feedback for asking the patient whether she was pregnant or wanting to get pregnant. We know that lithium is teratogenic. It predisposes to things like the Epstein anomaly and the Wolff-Parkinson-White syndrome. So you really don't want to be prescribing medication that the patient is potentially either allergic to or intolerant to, provided they are pregnant. This applies to any other station as well. Say, for example, you are explaining something like, I don't know, really, I can't emphasize this enough. Pregnancy is one thing you are expected to highlight for multiple reasons. So just make sure you do that. With regards to the side effects, there are, a list as long as your arm when it comes to side effects for medications. I would focus on the common and the dangerous, and I would state them as such. Okay, so I would tell the patient, I'm going to sort of talk you through a series or a list of common side effects that you are likely to experience. These include X, Y, Z, and then you move on to talk about the dangerous ones. With the dangerous ones, I mean, the one that comes to mind, for example, is agranulocytosis with clozapine. That's just textbook. It's a med school favorite. I would emphasize that it's rare, that it's uncommon, but also understand or make sure the patient understands that it's life-threatening. Don't shy away from asking the patient to explicitly regurgitate what you've said. So this brings me to my next point, which is chunk and check. With things like agranulocytosis and clozapine, things like teratogenicity and pregnancy, it's worth really asking the patient to regurgitate what they've understood. So I would say something along the lines of, can you please, in your own words, just summarize to me briefly what you understood from what the side effects of this medication are? And if you want to dwell that or take that even a step further, I would ask, so what's your understanding of what happens when your white cells, for example, go down? What symptoms are you looking for? okay, good. And what would you do if these symptoms, for example, do occur? Oh, all right, good. Seek urgent medical attention. So guide the patient through that, but make sure you explicitly state it, because you don't want the examiner to not hear you say that. Okay, examiners can be tired, they can be busy, they can miss things. So you want to really make sure you emphasize the important things to them. Moving on, if you don't know, say you don't know. I think anybody can, see through somebody who's BSing their way through the station. I'm sure you guys can do the same when you're practicing with your friends. So if you don't know, be very honest. I think that's quite commendable. It's quite admirable. Examiners like it when students own up to their problems and their flaws and say, actually, I'm not aware of this. But use this as an opportunity for you to prove how safe and how good you are as a doctor. So, essentially change that to a strength. If you don't know something, say, I'm very sorry, I don't know your question, but also do not stop there. So escalate appropriately. Say something along the lines of, my colleagues, my seniors are actually just, across the corridor. I'm going to go ask them, after this encounter, la la la. Or I can always sort of connect you with, appropriate services like the specialist nurses, for example, whose number I can give you. Make sure you give them a holistic experience. Direct patients to resources. If you feel like you're quite short on time and you don't have many more time, seconds or minutes to cover things, just say, sorry, I'm very sorry. I completely appreciate that we didn't have enough time to cover everything. But that said, I'm going to give you a patient information leaflet on, this medication or this condition. I'm also going to direct you to appropriate resources like the NHS website, for example, or the Royal College of Surgeons, or whatever it is, that's relevant. So bombard them with resources. Give them numbers, hotlines, specialist nurses, everything, to safety net yourself really more than anything, and to show that, to demonstrate to the examiner that you have an element of continuity of care. Moving on, keep an open mind. I mentioned this because of really many reasons. The main one is you guys have such a limited number of stations this year, understandably. So what Cardiff, my understanding, at least from what Faris said, is that Cardiff is really aiming to hit 2 or even 3, 4, 5 birds with one stone and really combine multiple specialties in one station. The one that comes to mind is postpartum depression. I think that's quite a relevant one that came up a few years ago. It's relevant because obviously it combines 2 specialties. It's a perfect marriage of psychiatry and obstetrics. And it also demonstrates the importance of highlighting every aspect of both specialties. So if someone presents to you with a postpartum depression, the take-home message is obviously you do the psych element of things. For example, you risk assess, but you also remember that you have another person to risk assess, which is the child. So you don't just focus on the mother or on the female in front of you. You focus on the child and you ask how they're doing, if they've been neglected, have they been, suffering as a consequence of their depression. So always keep in mind that you're not just risk assessing the patient in front of you, you're risk assessing patients around them as well. The obstetric side of things, I think we can all fall into the trap of forgetting the fact that the patient was pregnant a few days or a few weeks ago. A few weeks or days postpartum is still within the intrapartum period. So really do ask obstetric related questions. How was the birth? How was the labor? How is the female doing after giving birth? Is she experiencing any bleeding? Is she experiencing any pain? Is she lactating? Is she breastfeeding? Don't deviate too much. If you're asking a patient about postpartum depression, focus on the depression, but also highlight the fact that this is an obstetric station and that you have an awareness that this patient has only given birth a few days ago, and they might well be experiencing physical symptoms relating to the birth. And make a direct correlation between both. So ask if there's anything relating to her pregnancy journey or previous, pregnancies that may have contributed to her depression. Also, any station can turn to an acute station. I cannot emphasize this enough. Pretty much every station that I've had in my specialties station ended up being an acute station. So my recommendation might sound a bit extreme. I would personally memorize the emergency section of the Oxford Handbook very well, because it can turn into anything. My Lithium station, for example, turned into an AKI. Other patients had a seizure. So a few years ago, I think one of the most examples that stick to my mind is a psych station where candidates were expected to explain an antidepressant. they were handed a set of bloods essentially, by which there was only mild derangement, but quite a significant increase in urea. And a lot of candidates looked at the bloods and thought, what the hell's going on? This doesn't really fit with the picture. But actually, by keeping an open mind, you have to think that actually this ended up being an upper GI bleed, okay? So Cardiff has a very nice way of keeping things holistic and relating things to each other. So don't go into a psych station thinking this is just a psych station. Psych stations can turn into acute abdomens, they can turn into status, they can turn into anything. My friend who resat last year said that her clozapine station, for example, ended up being a pneumonia because, as we know, clozapine can cause agranulocytosis, which can cause an infection. So it was completely bizarre, it was completely random, but the point is, keep an open mind. This is how real life works, and this is what Cardiff wants you to do, okay? Do not go in with a narrow sort of view of things or a tunnel vision of things. Read up on psychiatric emergencies. This took me by surprise. I was introduced to psychiatric emergencies on the day of the exam. Didn't know that existed. I think we tend to associate psych emergencies with neuroleptic malignant syndrome or serotonin syndrome, but really there are actual psychiatric emergencies like, well, delirium, actively suicidal patients, and active psychotic patients. We would never, personally, I never came across how to manage somebody who's actively psychotic in front of me. So have a general approach of things. Look them up. I don't have any particular tips, but I would recommend you looking up the psych section of the Oxford Handbook of Clinical Specialties. There's, I think, 102 pages, very condensed, very straightforward, very nice about how to deal with psychiatric emergencies. Bear in mind, you need to adopt the general sort of A to E approach to everything. Make sure there's not any underlying physical cause that may be driving the psychiatric emergency. And obviously general measures like de-escalation techniques. Make sure that you are safe before anything, that your colleagues are safe. Importantly, other patients around the patient were safe. The psychiatric emergency I had was that the patient was essentially threatening you and the staff members with a knife. The patient actually had a knife with them and they were threatening, verbally aggressive, and etc. So what would you do? I was taken aback by that. So read up on psychiatric emergencies, adopt general principles like safety of yourself, safety of colleagues, safety of other patients, de-escalation techniques, calming the patient down, avoiding eye contact, all of these general measures, confiscating the weapon or the sharp object, etc., and involving members. I mean, you're not alone, so call the consultant, call security. In real life, you just call security, but in a NISCI, just be more holistic. And finally, for this slide, data interpretation. I don't want to labor this too much. I think I've mentioned that already, but communication stations can be anything. So don't be taken aback by sets of bloods, have an open mind, a chest x-ray, an ECG. The obvious one would be long QT and an antipsychotic, but again, it can be normal, completely normal. Don't make things up to accommodate the previous station or what you've been given. They can be completely unrelated. That's Cardiff in a nutshell. And an image, like Faris has told us. I mean, I myself was presented with a picture of a vagina last year. It still haunts me to this day because I did not expect it. It's not something you actively revise. And admittedly, it's not familiar territory either. So I was just looking at that laminated piece of black and white paper and thinking, what the hell is going on? So keep an open mind, basically, is what I'm going to say. Next slide, please. So onto my last slide. This one I think relates quite nicely to pretty much every station, maybe less so acute stations, but certainly chronic day stations and specialty stations. You need to emphasize the fact that you're going to treat every single patient you come across with a biopsychosocial approach, okay? I would mention that very term. I would explicitly mention it. Buzzwords like these make examiners so happy and elated. It's an easy tick boxing exercise. So say I would like to adopt a biopsychosocial approach when managing this patient, be holistic, address those, and then mention that you're going to also summon or seek the input of a multidisciplinary team. So mention a few, if you're dealing with a psychiatric patient or a postpartum depression patient, obstetricians, pediatrics, psychiatry, specialist nurses, etc. Mention these two terms at the beginning of every management plan you have, and you will not go wrong, okay? Briefly assess the impact of diagnosis on your patient. That's actually quite important. Whenever we explain something to somebody, whether it's you know, I don't know, a SUFI or a perphase or a postpartum hemorrhage or a preeclampsia, or whatever it is, we tend to underestimate the impact that that diagnosis has on the patient. So it's worth dedicating a few seconds or minutes, not minutes, actually, that's a long time, a few seconds of your time just asking, how are you coping with the diagnosis? You know, are you okay with it? Do you understand what the hell is going on? And do you have any questions for me? So again, relates nicely back to ICE. And finally, have a very structured approach. Whenever you want to manage a patient, even if it doesn't sound obvious, manage the patient from a conservative medical and surgical point of view, okay? You won't go wrong. You will never go wrong if you do that. You won't sound stupid if in a psych station you said medical conservative surgical. Obviously mention the fact that there are no surgical options here, but just mention it. It shows the examiner that you've got structure, that you're organized, and you have a nice way of thinking. And finally, this is not the most important thing ever, but lifestyle modifications tend to be easily overlooked in management. Don't underestimate those. So if you're talking to somebody about depression, you know, I know it sounds a bit trivial, but talk to them about, you know, the importance of exercise, the importance of talking to other people, the importance of diet, etc., before you hone into, you know, cognitive behavioral therapy and antidepressants, ECT, etc. Okay, so just be holistic and open-minded. And sorry, I think I've bombarded you guys with a lot of information. I think that's all I had to say. If something else does pop to mind, I'll let you know. But yeah, that's it for me, really.
Sorry, I muted myself. Thank you, Zaid. That was really good. So I've just put 3 summary tips, which are really, I think, applicable not just to the specialty stations, but also for the whole ISCE. In particular, though, for the explanation stations, my biggest advice would be to just ask questions, ask what they're expecting of the particular consultation, because there is a danger if you go into the explanation station of waffling on and essentially showing off what you know about a particular condition or whatever you're expected to talk to the patient about. Just bear in mind that the actor and the examiner will have particular things that are looking for, and they may only be addressed if the patient is given the chance to ask their questions. The other 2 tips I would say are applicable to all the stations within the ISCE. You're expected to be sort of competent at the level of an F1 by the time you sit your ISCE, and you guys will be assessed at the standard that you're expected to be at the end of phase 2, which is at the end of 4th year. So the kind of things that you will be seeing and dealing with and interpreting and talking about management in relation to your ISCE will be things that you see every day as an F1 or an F2 or within a GP practice. So just bear that in mind as you're going through each of the stations. If you're a bit stuck with the history or when you're doing an examination station as to what the differentials, your differentials could be, just remember what are the things you've encountered most commonly at med school. You guys would have had 8 weeks of GP and 8 weeks of shadowing an F1. So use that experience. What have you seen most commonly that's presented in a similar way? And use your differentials for that. I always advise students to try and confidently say 3 differentials when you're presenting back a history as well. And just remember that you're thinking of common things. And finally, with regards to how the stations are written and how they're standard set and designed for these finals, they are trying to make it so that they're, like I said before, conditions that you commonly encounter as an F1, but they also want you to be able to deal with the life-threatening conditions, which is why, as Zaid has mentioned, there's a few examples where stations have turned from being quite benign, for a lack of a better term, and then escalated into something like a pneumonia, something requiring a hospital admission. The chances are it's going to be like that for all of your stations. I remember my cardiovascular station, I can't remember where the setting was, but the examination, the patient was fit and well, but the differential I was expected to come up with was an acute coronary syndrome, because the vignette on the door was that they presented with chest pain, and all the questions and investigations were related to that. The same with my respiratory examination station. The patient I had was fit and well in front of me, had a diagnosis of COPD. The questions were related to an infective exacerbation of COPD. Yeah. Zaid and I have both discussed about the psychiatric emergency station. So there's a common theme running through here. They want you to be able to know the management of emergency conditions. They're not really gonna sort of veer towards largely sort of rare conditions and long-term management. They're going to be asking you questions related to interpreting acute things that you're going to be seeing essentially as an F1 on the wards, things like AF on an ECG, things like consolidation on the chest X-ray or a pneumothorax, things like a subarachnoid hemorrhage on a CT scan. So just bear those things in mind when you're approaching the station. Those are the things that are likely to come up. And remember, as I said before, if it seems straightforward, the chances are it probably is. It doesn't, these stations are not written by professors in say the specialty. They're not written to be as hard as humanly possible. They're written so that a standard medical student at the end of fourth year who's revised their stuff to a reasonable level and has turned up on placement, as you guys would have, can pass the station reasonably comfortably. That's what they're designed for on the whole. So thank you very much for listening. This is the feedback QR code. A lot of effort has gone into organising all these sessions, so we would very much appreciate it if you guys could just provide a little bit of feedback, because given the current circumstances, it may be that in future years we do this in a similar way, face to face, or we may continue to do it online, particularly as well for the fourth years who've got their exam coming up in May, and also for the second years coming up in June as well. So
does anybody have any pressing questions, by the way? Sorry.
Oh yes, that reminds me, Zaid. I had a couple of questions directly on the chat as
fine,
well.
I've read Omar's one. Hold on, let me see. If you're doing a psych pharmacology exploration station, would you risk assess? Yeah, I've answered that question, definitely. Yeah, I would risk assess any psych station, because it would always be relevant, be it a medication or a psychiatric condition. Definitely always risk assess.
So I actually disagreed slightly with Zaid on my answer. Sorry for that. But essentially, the way that they write the vignettes for the station, they should all the time, if they want you to do a risk assessment, include it in the vignette, so it's reasonably stated. I would say if it doesn't include that in whatever station you're doing, so whether it's the pharmacology one or say an examination one, if it doesn't include it, they're not expecting that. But just bear in mind what the vignette reads. So I was examined on the fourth year formatives yesterday, and the station that I was examining on was the interprofessional communication one, and that actually had risk assessment included on the vignette. If you knew what the scenario was in the context of that, it made perfect sense to do a risk assessment. It wasn't a psychiatric station, it was an obs and gynae one, but it was a risk assessment relative to what condition they had. So just bear in mind what's on the vignette of the station. Having said that, if you feel it's appropriate, and I wouldn't say it's wrong what Zaid has mentioned, if you feel comfortable doing a risk assessment in an explanation station, often what might be appropriate, I know when we both sat it with 11 minutes, often what we practiced doing was taking an initial history in the first couple of minutes if you could, and then that is a very appropriate time to do a risk assessment as well.
Yeah, definitely.
So I hope that gives you an answer to that question. So sorry, I've seen the chat has got a lot more.
Any other questions, guys?
So guys, thank you very much to Faris and Zaid for the excellent explanation and all of the tips. We personally feel that is very helpful, especially even for us F1s. I think it's a good reminder of what everything is. So for any more questions, we are actually running a dedicated session for question and answer tomorrow. So if, in the interest of time, if we could carry on all of your questions to tomorrow, 6:30, same link. There will be some tutors who comes from the different days, and we will be able to answer the question as a panel. It will be fun, it will be relaxing. So we will hopefully see some of you guys tomorrow. I think someone's trying to get the feedback form again. Faris, could you go back one slide?
I'm muted again, sorry. Oh, that is the wrong thing, sorry. I've not improved technologically wise since there. Has that come up?
Yeah, that's good. Right, guys, I will hand you over to David and Sashi because I have to eat and go to night shift. But thank you very much, guys, for coming over.
Anthony.
Yeah,
right.
See you, Anthony.
Bye.
Thank you for I think it's a fantastic session. I mean, if the people are staying there, you can ask them question if you guys want, happy to answer. But otherwise,
yeah, I'm happy to answer the question tomorrow. Someone asked, I typed in a reply. They asked if they would fail if they missed, say they didn't know what an ECG showed, but they knew it was perhaps abnormal, and they said they would escalate to the senior. So the way that the ISCs are marked, you're marked in relation to, so it's 5 domains. I can't remember what they all stand for off the top of my head. 2 of them are essentially your clinical competency. So one of them's for communication. 2 of them are for communication, sorry. One of them's for content. I can't remember what the other one is. One of them is for professionalism, which virtually everyone manages to pass that as long as they're not rude or offensive to anyone during any point in the station. One of them's for diagnostics, and one of them is for clinical care and management. And essentially, you're graded from excellent to fail on each of those. So if you got to the data interpretation section and you were absolutely clueless to the point that you didn't say nothing, so you would fail that, you would get marked to fail on that domain. But say you were exceptional on the communication part of that station and you were marked an excellent for that, you can see how it sort of balances out. There isn't a point where, say, if you do something absolutely wrong completely, so if I, for example, in my respiratory examination station, I completely missed the diagnosis that the patient in front of me had. I didn't think they had COPD because I thought they had clubbing in their hands, which was completely wrong. I still passed the station, but I probably would have failed one of those domains. But I still managed to pass the station because I knew the management of COPD okay. So what I would say, if you are generally baffled what a data interpretation is in front of you, go through whatever structure you've learned for talking through and interpreting it. So if it's an ECG, so if you go through the rate, the rhythm, confirming things like patient details, describing whether you see P waves, QRSs and T waves. And then at the end of that, if you're still, because going through that process, you might actually identify what's wrong if you just talk through it. You might actually see that there's, for example, a STEMI that you may not have noticed before, T-wave inversion, or some other abnormal finding. If you still haven't done that, I would just say if it's still worth highlighting that you think the ECG or whatever investigation is abnormal rather than normal. I think they would be more worried about a student who thinks that something is normal, say something such as findings of acute coronary syndrome or a bleed on the CT scan, and you didn't say anything that would suggest that was abnormal. I think they would be more worried about that, whereas you said this is abnormal, and like Zaid was saying earlier on, be honest, say I'm not quite sure what this means, but I would escalate that to my senior or whoever as soon as possible. Millie has asked, is it an excellent pass, borderline, or fail? Okay, so this is a bit complicated to describe. Sashi and David, you don't mind me explaining this on here? I know it's slightly over long in the session.
No, it's fine. You can explain it. Yeah.
So the way that so the way that they mark your ISCIs, so the pass mark is set doing something called borderline regression. So it very much depends on how everyone else does in a station, whether a borderline counts as a pass or a fail. So if I give the example of the station that I failed, so the station that I failed, I was actually marked to pass, but because I'd scored a borderline in, I presume, one or a couple more sections. Essentially, it meant when they compared me to other students that day who were sitting in the same station, who presumably would have scored a pass or an excellent, that meant that my borderline was brought down to a fail. So in other words, it very much depends on how other people do compared to you sitting that station. So if they found that they did a station and lots of people were scoring borderlines or fails, the chances are that would mean if you did score borderline, that you would be that station, you would actually pass it. Whereas if it was the opposite, if you scored borderline, but the vast majority of people doing that station scored an excellent or a simple pass, then the chances are that you would be marked down to fail that particular domain. But remember, so the way that they mark it is based on domains. So they add up all the domains to correspond to a pass mark or a fail mark. I hope that helps to answer the question. It is a bit complicated. So I would suggest my general advice would be not to worry about it and to just try the best that you can. Inevitably, there will be some stations that are really difficult and some stations that are really easy, and it's very hard to tell which are which. So I don't know what Zaid's approach would have been to this or the other guys who are on this, but I would just say, give it, like, try your best and try not to worry. Like I suppose you'll have less of this because you're doing it over one day, but I found the hardest thing over the 3 days was chatting to other people about what they'd done and hearing sort of the different things and suggestions, and finding it quite hard to judge how you've done in the station. But if you've done it because of the pandemic and everything, it might be slightly easier this year, and because it's all done in one day.
Okay, thank you for excellent answer. In the interest of time, we might have to close it. For those who, thank